I'm Emma Cooksey. I'm the host of the Sleep Apnea Stories podcast, and I'm super excited to introduce our guest today. I've been asking Professor Vik Veer to be on my podcast probably for 3 years, and he finally said yes. For anyone not familiar with Professor Vik Veer, he's a leading ENT surgeon in the UK. He serves as the head of sleep surgery at the Royal National Ear, Nose and Throat Hospital in central London and also practices at Queen's Hospital in Romford. He's a passionate educator and communicator. He runs a YouTube channel with over 25 million views. He has just invented a new pillow, a type of positional therapy device for sleep apnea. But one of the things I was really excited to ask him about was the multidisciplinary team he's been working on with other colleagues, other doctors, dentists, surgeons, myofunctional therapists, all these different people working together to try and solve people's sleep apnea or at least give them the best treatment options possible for that individual. So I love his approach and I really enjoyed getting to ask him all about it. Just to let you know, in the notes under the video, you're going to find so many different free resources. So Vic has given me a ton of different things that you can link to. So he has a free sleep questionnaire that he talks about in the episode. He's got a newsletter you can sign up for. There's a tonsillectomy book and links to his YouTube channel and his new Side Sleeping Pro pillow. So they're all there for you. There's also the link there to a PDF toolkit I put together as part of the sleep apnea squad program I run at Project Sleep. So if you haven't heard of Project Sleep, we're a non-profit patient advocacy group, and my day job outside of podcasting is putting together free resources to help people like feel more educated about sleep apnea and raise awareness about it. So the PDF toolkit I'm talking about is free and it covers all of the different treatment options for sleep apnea and how to access them. So I think it's a pretty helpful guide, like especially if you're pretty new, if you've got a fairly new diagnosis with sleep apnea, it just helps you to see the full landscape of all the different options. So without further ado, here is my conversation with Professor Vik Veer. Okay, well, thank you so much for joining me. I really appreciate it. So the first thing I really wanted to dig into was the fact that you even started a YouTube channel to begin with. There's
Yeah.
not a lot of doctors, you're renowned ear, nose, and throat surgeon and probably really busy. What was it that made you want to start your YouTube channel in the beginning?
I mean, it started in COVID, like almost every other YouTuber in the world. During COVID, the sleep department just got closed down. My managers told me, look, Vic, sleep's not important. We need you to do airway surgery somewhere else. And they can just use CPAP anyway, which infuriated me anyway, because I thought to myself, no one can see me unless they use CPAP anyway. And there are no CPAP machines out there because they've all
Right.
been taken up by COVID.
Yeah.
But anyway, I was forced into doing sort of airway surgery, sort of making holes in people's necks so they can breathe, or scraping out COVID from the inside of people's larynxes. So my department got closed down for about a year and a half, less than a year and a half. And I was like, well, I can't see anyone. I can't operate on anyone. I can do sleep studies. And so typically on a Wednesday afternoon, I'll just cold call my patients and say, oh, hi, yeah, my name's Vic. You don't know me, but I'm your sleep surgeon. And I couldn't do anything. But I said, look, looking at your sleep study, you should really sleep on your side. And I found this thing on Amazon. If you get it off Amazon, you can sleep on your side and your sleep apnea will go from 20 down to 7 or something. And then I'd go, ooh, maybe you should try this, because if that didn't work, and then after doing those clinics, which I felt completely sort of neutered in doing, I thought, actually, I'm saying the same thing over and over again. Maybe I should just put a video out and I can say, you know, that nasal spray I told you to use, just look at that video and it'll tell you what to do. But let's get on to the next thing. And I was trying to be like more efficient and I was gamifying. I can get through more patients quicker
Yeah.
and I could just point them to videos here, there, and everywhere. But it didn't, it sort of backfired a bit, because then people started following me, which is a disaster. And now my clinics are even more busy than they've ever
Most people would think the other way around, that it's like a big success. I do think
been.
that one of the things that stands out about your YouTube channel and what people tell me about it is just how patient centered it is. Like, I think there's a lot of other doctors trying to put out helpful information, and not to say anything negative about them, but it comes across as a much more I'm the doctor, you're the patient, almost patriarchal, like you should do these things, whereas a lot of us feel like you're speaking to us on the same level, which is amazing.
Yeah. Yeah, I don't know how, what do I say to that? I think we all have our different styles. I've
Yeah,
never been good at being the patriarchal sort of professional doctor. That was always a thing that marked me down in all my exams.
yeah,
I was doing more of this sort of banter medicine rather
right.
than sort of tell me about your history of presenting complaint. I was never very good at all that, and I never really stick to a script. It was always, so you're from Florida, and and I end up going down that route. And in the end, I remember to ask questions about sleep.
Yeah,
But that's, I think that's just the way I am, and it's easier for me to do it that way rather than me pretending
yeah.
to be someone else.
Do you want to just share with people, because we're mainly going to be talking about obstructive sleep apnea today? Do you want to just share with everybody briefly, like what that condition is? Just because I'm aware that a lot of people listening have different levels of knowledge and might be coming to this already having had a diagnosis, or some people might be coming to it only having symptoms and they're about to embark on this. Do you want to just give us a brief overview?
The way I try and describe it, someone who doesn't know anything about sleep apnea, is that I think most people know what snoring is, that sort of noise that everyone knows. And if you can imagine that something's flapping around in the back of your throat, sort of getting in the way of your breathing, and then imagine if that thing that was getting in the way of your breathing got so big that it blocked you completely. Now, just blocking you is not sleep apnea, it's just blocking your breathing ever so slightly. You only get what's known as obstructive sleep apnea when it blocks you so much that your oxygen levels drop ever so slightly. Your brain goes, oh, this is serious, wakes you up a little bit so you can go like this. And then you go, what? You don't remember any of this, but your brain goes, take a breath, you're losing oxygen. You take a breath, and then your brain goes, okay, everything's fine now. And then you start slipping away back into sort of blocking your throat again. So it's this sort of repeated blocking of your airway. You wake up a little bit, and then you start falling asleep again. You get deeper in, and something in your throat falls in and blocks your breathing, and then you start all over again. I mean, on the face of it, it doesn't sound too bad. It just keeps waking you up. But if it happens a lot, then you feel like you're not getting enough sleep because you keep getting woken up. You never get into deep sleep because your body keeps waking you up. And the fact that you have to pump adrenaline into your body to wake you up, your body and your heart and your lungs, all of this doesn't like that sort of blockage, doesn't like the sudden adrenaline rush. And so you get all these other problems that come on later on. So that's why we treat obstructive sleep apnea. We don't want all those other things happening, like high blood pressure, infertility, weight gain, and all these things lead on to other things like diabetes, heart attack, stroke, and the stuff is really scary. But it's down the line, and if you
Mhm.
can catch it early, A, you might save your marriage, but B, you might live a bit longer,
And
which
also
is,
with, I think, with a better quality of life as well. Like when I
yeah.
talk to people, I think sometimes they don't want to think about all these things that could happen in the future, but they certainly do want to be less sleepy during the day and not falling asleep at the wheel and there for their families and able to be at work and not excessively sleepy. So most people listening will know that CPAP is one of the most commonly prescribed treatments for obstructive sleep apnea. So I guess I want to understand, like, how do people know that they need to go and see an ear, nose, and throat surgeon? Or like, should everybody go and see an ENT? Or is it specific people? Like, how would we know?
I'm not sure about the rules in America. We've slowly been changing our rules in England because CPAP is great if you can use it. And the people who use it, they will not get it out of their, won't let you take it out of their hands because they feel so good with it. And they know, just as you were saying, that if they don't have it, they feel just dreadful during the day and they feel that their lives are ebbing away without it. Whereas if they got the CPAP and they can use it, it's great. The trouble is, a lot of people find it hard to use CPAP, either because they've got a blocked nose or there's a big obstruction, like big tonsils in their throat, or they just haven't quite got mastered the whole nose mouth thing because they've been struggling for such a long time. Some people just hate sleep so much because they just dread going to bed, and then they already dread going to bed because they know they're going to wake up tired and have a headache, and then you're asking them to slap something on their face all night. It's scary for people, so psychologically it's hard. So for lots of reasons, some people do brilliantly, but a lot of people don't do so well. And in our guidelines, we say that before you use CPAP, you should check you don't have big tonsils, because it's really hard to move meatballs out the side of your throat and get air down it. You should get rid of the meatballs, because in a lot of people that solves the problem. You know, in young, fit American soldiers, there was that study done years ago. It was close to like 90% cure rate in those people. But it's really, really hard to use CPAP with a blocked nose. You put a strap on your face and it pretty much closes your mouth most of the time. And you're forcing all this air through your nose. If you've got a blocked nose, then you sort of, and you pull it off in the middle of the night. And so, yeah, ENT are the people who do those things. And actually, anyone could learn to look at someone's tonsils, and anyone can go, and does it feel blocked to you, all that sort of stuff. But I don't think it's necessary to everyone see an ENT surgeon. But if you're worried you've got a blocked nose, or if you look in your mouth, you see these two IKEA-sized meatballs in your throat, then maybe you should see someone who can deal with both problems.
So tonsils and then also nasal obstruction where you can't breathe well through your nose would be really good reasons to go.
I mean, I'm going to complicate it further, because some people go through the whole day and not know that they've got a blocked nose, because they say, oh, I feel fine, because most of the time they either breathe through their mouth or they don't realize they're breathing through both. The way to tell is before you get up in the morning, you just wake up, open your eyes, and then before you get out of bed, before you go downstairs to make your cup of tea, or in America, coffee or whatever, just do.
People in America do drink tea.
No, they don't. That's a lie.
Although I'm saying that, and my mom is about to come for a week next week from Scotland, and there's just panic because we're like, we don't have any tea bags. And like,
she's going to have to take the next flight home. Yeah.
I know.
So before you get out of bed, just sniff and sniff. And if you find that one side's a bit wet or feels blocked, then you know that although you're great during the day, you probably have a problem at night. And that's the time that we're really worried about.
Yeah.
Another way to check is to give yourself the Otravine or Sudafed nasal sprays, and see if you suddenly feel, oh my God, I can feel loads better. And maybe you're really blocked and you've just got used to being blocked and you've just forgotten what normal is.
I want you to kind of explain about this DISE procedure, the drug-induced sleep endoscopy. Do you do that with everybody you see with sleep apnea, or just certain people?
I kind of do it with everyone because I love it. Well, we invented it, so we kind of like it. So yeah, years ago, I think in the 90s, one of my predecessors in our hospital made up this thing, and it's drug-induced sleep endoscopy is all about trying to figure out why you have sleep apnea. So lots of people know how bad their sleep apnea is. They have a sleep study, they wear it or on the end of their finger or something like that, and they give it back to the doctor, and the doctor says, oh, you stop breathing 15 times an hour or 20 times an hour, whatever. So you know how bad you are, but you still are none wiser why you've got the problem in the first place. Is it my big tonsils? Is it my blocked nose? Is it my tongue's too big or whatever? And so that's the point of this investigation. I get you to lie down on the bed. I put a little bit of sort of a sedation in your arm so that you fall asleep and start snoring away in front of me. And then with a little telescope, I look down the back of your throat and just look to see which parts of your throat are flapping around. And that's where the snoring is coming from. I go, right, write that down. And then which parts of your throat are blocking your throat and stopping you from breathing 15, 20, 30 times an hour. And I go, okay, so this is why they're blocking their throat. This is why they're snoring. Here are all the little factors that are causing their problem. It's normally multiple factors. And then I wake people up and show them on my laptop like this and say, look at this. This is your epiglottis, or this is your lateral pharyngeal wall, and this is how we could fix it. Actually, you've got this problem as well, so we can mix these two operations together. But it's a way for surgeons particularly. It's not that useful for CPAP because CPAP pretty much works on everything. Some things it works better on than others. Like it's absolutely amazing CPAP for a lateral wall collapse. With an open nose and lateral collapse, people love it. And you can see, you said, well, you should try CPAP. There is no reason for me to
Right.
do an operation. But if you don't like it, we can always do the operation on the lateral wall. And some things it's not so good at, like an epiglottis problem, for example, because it's blocks your breathing if you have an epiglottic problem. So you don't really need one. But if you've tried CPAP, you've tried a mandible advancement device, you tried all those other things in my videos, like the exercises for your tongue and your throat and
Yep.
a tongue retaining device, INAP, all that sort of stuff, and you just think, oh, I just want to know what's going on in there, then I'm not going to operate. I've got, as I said lots of times, I think 43 different operations for snoring and sleep apnea. I'm not going to try them all on you.
And there are videos on almost all of them. So if people like want to go to, I mean, I feel like you've discussed so many procedures on your channel.
Yeah, I try. I feel like I haven't done any because every time I make one, I think, oh God, it's too gory. No one's going to want to watch this. And then I've got a lot of videos which I haven't released because I just think the thing I worry about is I get a lot of views for like the tonsil videos and things like that. And I just worry that people are coming on just for the gore factor and it's not educational. You don't really need to know what a barb suture pharyngoplasty looks like,
Right.
or like what a hyoid suspension looks like internally. You really want to know how it's going to affect me, if it's going to work,
Right.
what are the risk factors, what am I going to feel like, all that sort of stuff. And so, although it's great for viewership, I get 4.5 million views, fantastic, aren't you amazing? It's just vanity.
Right.
It's not helping anyone. It's just making people
Right.
go, wow, isn't that weird?
I don't know. I think it is help. Maybe it's because I'm a nerd and I love watching stuff like that. But like, I do think it's helpful to kind of have an idea. So I think one of the things a lot of people struggle with, right? People who are lucky enough to live near you and be able to, whether they're private or on NHS, able to come and see you. That's great for those people. But a lot of the people listening probably don't have access to you to actually look at their own situation. I don't know if it's like this in the UK, but here there's a vast difference in training and people, how much they specialize in obstructive sleep apnea.
Yeah.
So I feel like it's kind of a balance between certain people thinking they want to explore, say, like a hypoglossal nerve stimulator implant. And so they find surgeons that do that specific procedure, or there's other people who don't really know and they're just trying to find the person with the highest level of training. Is there a particular way to navigate that or not really? Because people
Well,
ask me all the time, and I'm just like, beyond kind of like the International Surgical Sleep Society, I think it is.
yeah,
Um,
ISSS.
so where would you start, I guess, is trying to find somebody.
In the UK, I cover the whole UK. So anyone in England can come and see me, England and I think Wales as well. But yeah, you're right. My viewership is slightly bigger than that.
Yeah,
Um, it's really hard. The problem
yeah,
is
it's really
that
hard.
sleep surgery, particularly, is only 30 years old or something,
Right.
40 years old. And
And
so,
changing so rapidly.
yeah, I never got taught any of this at medical school. It's
Yeah,
just because I was interested in it that I traveled around the world talking to people and asking people how they did it and go, oh, really? And then tried it out and modified it with time. And I mean, there are only about 5 of us around the world that do it
yeah,
all the time.
yeah.
And the 5 of
I
us keep
think
in touch.
that's a lot of it's about patients getting educated themselves as well about what the options are and trying to find the best people to help them.
Yeah, I mean, I try and sort of do that in my YouTube channel. I sort of say, well, a simple thing is just take out your tonsils, which everyone learns on day one.
Yes, yes,
That or
absolutely.
fix your nose. And so
Yes,
I focus on stuff that anyone can get hold of.
yeah,
And then outside that, I'm if someone comes to see me, I teach them like how to do an anterior platoplasty because that's the best way to stop snoring really easily, and that doesn't require any special sort of skills. When then you get more complicated. But I think the route that I've tried to take is to get everyone excited about these implants in this country
yeah,
because nobody does any sleep surgery in our country until we got implants. Now everyone's, oh my God, this is so exciting. And
yeah.
now there are centers opening up everywhere.
Beautiful segue because that's my next thing I want to ask you about.
Okay.
So, for people here in the States, so we've had the Inspire implant out for a while, so people have some awareness of that. We only just got FDA approval for the Genio implant here. And then I know there's some other ones which haven't yet been approved. So do you want to just start by talking a little bit? Because I know that you do both of those, right? You do the Inspire and the Genio.
Yeah.
So from a patient's perspective, what should we like? What are the differences between those two? Is it just sort of a preference, or are there reasons that someone would get one over the other?
A lot of it's preference. There are in the Venn diagram, they're very overlapped.
Right. You might want
But
to just explain what the hypoglossal nerve is, what it has to do with
okay,
obstructive sleep apnea,
just
and get into it in that way.
okay. Thank you for directing me carefully. All right. So the hypoglossal nerve is a nerve that comes from your brain, comes round here, and then goes into your tongue here. So hypo means underneath, glossal means tongue in Latin. And so this thing comes up here and goes into your tongue. And in that nerve, there are nerves that push the tongue forward, push the tongue back, and sort of stabilize the tongue and rotate it slightly. And so it would be amazing if we can get those nerves that bring the tongue forward. So if you're lying on your back and you're going and you're stopping breathing, sometimes it's because your tongue falls back and blocks your breathing. And if we could just turn on that nerve that pulls the tongue forward, it moves it out of the way so you can breathe behind your tongue, which is
Right.
the whole thing about these implants and things like that. So the Inspire implant, the way it works is that it's used on sort of pacemaker technology. So it's been around since the 1960s. So it's really, really solid. Millions of people have had these implants before, but they're now using them for these implants. So it
Right.
sits, you see, it's quite thin, just
Yeah.
about there. And it sits just underneath the fat inside your chest, just about here. So there's a little cut there. We plop this in, and this is the battery and the computer. And there are two little holes here. One hole has a wire that goes around and sort of sits in between your ribs, sitting just near the lung. And the point of that is just to sense when you are breathing. So when you take a deep breath in, it pushes against it and it has a pressure sensor that feels it. And when you breathe out, you get sort of like a negative pressure. It pulls it away. And so you get less pressure. So
Hmm.
now this computer knows when you are breathing, when you switch it on at night with a remote control. Then there's another wire that comes up here over your collarbone, all the way to those nerves on the hypoglossal nerve that brings your tongue forward. So there's another little cut just there, which you get to that nerve, you swizzle this little wire around it, and then you just stitch everything up. And what it does is that when you turn this thing on with the battery remote control, you turn it on like this. There's nothing external, it's all internal. Every time you take a breath during that sleep, it will activate that wire and it will just bring your tongue forward. And then when you're not taking a breath, it flops back again. So you're not sort of overstimulating that nerve the whole night.
Hmm.
And I think 180,000 people have had these implants in the world, to the point that airport detector people know all about them now. So
Yes,
everyone
yes.
knows that it's like a pacemaker, basically. And
Yep.
it's been tried and tested. And as you said, I think it's been around for over 10 years now in America. And you guys have done
A
loads of work
lot.
on it.
Yes.
The Genio, which is that one, I'll try and make it a bit closer, is like a little chip that, so it's, if you think about it, it's slightly less invasive because you make a little cut just then. You only have the one cut.
So
And
under
this,
your chin for anybody listening in audio.
oh, sorry, under your chin,
It's
it
okay.
sits just about there.
Yeah.
And it's inside, it's not external at all. And you see there's two little paddles on either side, if you can see that. And so
Hmm.
you want the nerve, the hypoglossal nerve, to go past here. So it sits on top of it. It doesn't twizzle round. It
Hmm.
sits on top of it. And then when you activate this thing, it activates the left and the right, which is slightly
Hmm.
different from the Inspire, which is
The
only the
Inspire
right.
is just one side.
Yeah. And so it brings both sides forward like that. But the difference between this one and the Inspire is that this is a big battery and there's no battery associated with this. So you need a battery to charge it each night. So that's another difference with it. Although you don't have this incision here where the battery normally goes Inspire, you need to stick a battery on each night. So this is sitting underneath your chin like that. And then it's inside your skin. It's all been stitched up. It's all healed up. And then each night you need to get a battery, which looks a bit like this. And you charge it up like with a
Hmm.
normal USB, like your mobile phone with these
Yep.
USB things. You stick it on like that. And through the skin, the power is transmitted, a bit like when you put your kettle on. There isn't like a spike or anything. It just, the
Not
energy just
like an
goes right between.
American kettle, but a British kettle that sits on a base.
Oh, American, what did they do?
Americans have weird, it's like just a kettle that you put on the stove top and it whistles when it's finished. They don't really have
Oh, really?
I have an electric kettle. Like they do
Because
have
you're
them.
half Scottish. Yeah.
Yeah. I mean, I'm totally Scottish. My children are half Scottish. But yeah, we have a kettle. You can buy them, but people, yeah.
People don't do it.
No, not really.
Okay. Well, there's got to be something in America
Yeah,
which
I know
it's,
exactly what you're talking about. It's a base that you put the thing on.
yeah, like a wireless thing where
Yeah,
you
yeah,
charge
yeah.
your phone. Okay,
Yep,
cool. So that you're charging it through the skin like that. So they're not touching, but you're
yep.
charging through that space. And so it sits like that. You stick it on like that, and it charges it through the night. And so it works through the night, and then you just take it off and it stops working. You charge it. So
Yep,
it is, I guess, less invasive because you've only got one cut, but you do need
right.
to put a thing on each night. And there's little differences about if you can have an MRI, if it's going to get picked up at the airport, and little things like that.
And also like men have to shave, right? Because they have
Yeah,
to stick the battery underneath their chin.
yeah, that's a deal breaker for a lot of men. Yeah, it was difficult during COVID. Yeah, we all had to shave. It's not, yeah, and so it's your identity. It's like telling a girl you have to cut your hair off. It's
Yeah.
hard for people.
And so one of the things I think is really interesting about the Genio thing is so it's not necessarily sensing when you're breathing. It just
Yeah,
is set to a I think the person that I talked to kind of explained it that they look at your sleep study and they kind of just set it roughly to what they think your breathing pattern is.
yeah. I mean, a little bit. We sort of guess. I mean, most people are roughly sort of 14 sort of breaths a minute and all that sort of stuff. But with the Inspire, because it knows when you're breathing, it'll
Right.
only activate when you're breathing. And so it synchronizes with you. Whereas with the Genio, it's just set off at a pace which hopefully will be in which hopefully you'll be okay with. And because you can't breathe without it, you just get into sync with it anyway.
Yeah.
And so it may be a bit fast for some people, then we just dial it down a little bit. Or
Yeah,
you maybe actually,
that's a really good point. I think people that I've talked to who have I don't know anyone that's had the Genio yet. I'm excited for that. But a lot of people that I've talked to who've had the Inspire implant, a lot of them have told me a lot of it's down to calibrating the specific settings. Like I think sometimes people think that, they go one time and then they're done. But a lot of it is this follow up to make sure that the settings are where they need to be for it to be working. Is that what you're finding? Like you're doing quite a lot of follow up with people just to make sure it's
yeah, actually,
right?
my next video
Yeah.
is exactly on this point.
Okay. Yeah.
I was doing that this morning. So, like the guy who I'm going to be showing in the next video, he came in saying, I'm off my CPAP. I feel great, but it just doesn't feel like it's in sync with me.
Yeah.
And so we had to change the number of times. This was for the Inspire.
Yeah.
So it was meant to be picking up his breathing, but it was just a little bit slow for him because he's one of these people who even the slightest interruption in his breathing seems to wake him up.
Yeah.
And he can go up to level 8 or something on this thing. And, his tongue was interfering with the air conditioning. It was going right out. There was no need to go that far. I
Right.
said, bring it back down to 2 or 3 because that's all you need. We just need to get the sync working better. So we
Hmm.
just needed to start off a little easier, quicker. And we thought that would be it, but actually he didn't like that. So the way the electricity is passed is that it comes on slowly like this, and then it drops off. So instead of it going like this, but like a I don't know, like a curve like this, we just made it a bit more quicker
Yeah.
rather than narrowing it, which is what we tried first. We thought that would work. It didn't. We
Hmm.
just sped it up and changed the curve going up, the amount of
Yeah.
energy being passed quicker. And little things like that, from what I understand, most people take about 12 months of tinkering with it
Yes.
and playing around with it. And like one of my patients is saying, who's actually quite good at it, he's like saying, on a normal night, I do 5, but if I'm out with my friends at a
Drinking.
golfing party thing and I don't want my friends to think I'm a snorer, I just turn it up to 6. If I've had a bit too much to drink, I turn it up to 8.
Yeah.
And so you just decide, because I should say what I mean by that. So on the back here, there's these little ups and downs. And so you can turn up the electricity or the energy being
For
passed to you.
more stimulation kind of thing.
Yeah.
Yeah.
So you said, my wife can tolerate a little bit of snoring. And she says I gently purr at night, but you don't want that to happen with your mates.
Right.
So you turn it up and down like that.
Got it. Really good explanation with the golfing trip. Yeah, I think that's one of the things that speaking to a lot of these people, they maybe just don't realize that ahead of time. So it's maybe just good for people to know what to expect, right? That it's going to be
Yeah.
a process and going back and
It's
forth and stuff to get
I
it.
think a lot of people think that it's just something that goes into like you update your Microsoft and it's all
Yeah,
solved. It's more of it's like CPAP. It takes time
right.
to you have to focus on it and say,
Yes.
am I tired? Am I not tired? And
Yes.
should I try a bit higher? And there's a lot of calibration, and
Mm.
titration, and it's not easy. And that's why the good thing about CPAP, if you don't like it, just take it off. But if you got this or this stuck in your chin, or in your
Yeah.
it's a lifelong thing. It's a commitment.
Yeah,
And
yeah.
so we try really hard to put lots of barriers in people's ways to make sure that they really know what they're letting themselves in
Yeah.
for.
Because it truly can be life-changing when people find the right treatment option, whether it's this or something different. Just from speaking to so many people, it's just so worth it in the end if you find the right thing, but it's just kind of getting to that point. So one of the things I wanted to ask a little bit about, like what's coming next with hypoglossal nerve stimulator implants. Do you want to talk a little bit about that?
So you're talking about Restera, aren't you?
Uh-huh.
So I'm helping a friend of mine who is working on a team called Restera. We did a few last year where what we're trying to get away from is implanting something that requires a big operation and all that sort of stuff.
Yep.
So they sent me off to, I think, Belgium to teach me how to use an ultrasound machine because ENT, and we don't do an awful lot of ultrasound unless you're sort of a cancer surgeon. So they taught me how to do these ultrasound and find the nerves in your neck, which are tiny little sort of 1 millimeter strands. And I'm not very good at ultrasound, so it took me a bit of time to learn that. But the point is, what we're trying to do is use an ultrasound. Let's pretend this is an ultrasound. And I know now where the nerve is. And the idea is to put an injection whilst you're sitting in like a chair, like over there. Put an injection next to put this little pellet right next to your nerve. And then pull the needle out. And then that's one pellet put next to that nerve. Then you can do the same on the other side. So you can do the hypoglossal nerves just at the right spot. And we've been testing out other nerves as well to open up the airway even more. So
Mm.
there's the antecervicalis down here that we want to do, which, how do I explain
So
it?
it's a much smaller thing that you're
It's
putting
like
in
that
there.
big. It's like about like a little nail,
Yep.
the length of a nail. It's quite thin. And it's enough to get inside an injection needle.
Yeah, yeah.
Um, and so you just put it next to that nerve, in this nerve as well, because this nerve sort of pulls okay, how do I explain it? Teeth are like this, the tongue's coming down like that, and your voice box is like this. If you bring the tongue out the way, that's great. But wouldn't it be great to turn this so you can breathe like almost like a sword swallower? You could turn this towards as well, because you're trying to just go bring everything open so you can get the maximum air, which is, with the whole sleeping like this sort of thing, it
Yeah.
straightens out the airway so the air can go in and out without it going around
Yeah.
chicanes to get to where it
Yeah.
needs to get to. And like the side wall of your throat collapsing in, or you can actually put the pellets inside muscle so it contracts like this. So
It's
we're going to put
fascinating.
these little pellets everywhere, but they have to be powered because they're not batteries either. So we're thinking about putting a pillow with the charge inside that. So when you lie down the pillow, it starts working. Or I think they're thinking about a collar for some people.
It's
They
amazing.
haven't got to that point, but we
So,
tried it out on some people last year and it worked great.
so how far away from actually being available is that?
So they promised me 2027,
Okay.
but I'm guessing it's going to take longer than
Okay.
2027. Yeah, we're doing human studies where hopefully the plan was this year we were going to do implants that people take home away with them, because so far we only put them in, saw that it worked on us like a sleep study
Yeah.
in
And
front of
took them
us,
out again.
then took them out. And the great thing about it is it seems to work on people who are bigger. Like these implants you can't really put into people who have a lot of weight on
Higher
board.
BMIs, yeah.
Yeah. Whereas this one seemed to work on people who had a BMI of 40 plus. So
That's
it
great.
seemed to work really well.
The next thing I really want to ask you about is your new positional therapy pillow that you designed.
There.
So
Yeah.
you're a downright inventor at this point. I think that positional therapy for obstructive sleep apnea is one of the most overlooked things that people can do. Do you want to explain to anybody listening that doesn't know anything about this what positional therapy is, and then just get into like what you saw and why you decided to become an inventor?
Okay. Lots of people with obstructive sleep apnea have lots of different reasons why they have it. But many people have a tongue-based problem or some other problem that changes with position. So like a lot of wives will know that if their husband is snoring, or the other way around, that if you roll them onto their side, they stop snoring. And the same thing happens with sleep apnea. When you turn someone onto their side, it can often help quite a lot in terms of reducing their snoring or improving their breathing. With regard to the obstructive sleep apnea, we sometimes think it's the tongue falling back because if you're lying on your back, the only thing in front of your airway is your tongue. And if you're lying on your back, gravity just sort of lets it drift back. The good thing is that we have tone in our body. We don't go completely limp when we're in bed. So
Mm-hmm.
we have a little bit of tone that keeps it at bay. So normal people are fine. But people with obstructive sleep apnea, because they've lost a lot of the tone in their throat, it falls back and starts blocking their breathing. Or their tongue is just so big because there's tonsil on top of it or some other problem, or their jaw just slogs back like that, then
Mm-hmm.
it can block their breathing. And it's even worse during dream sleep because all your muscles turn off during dream sleep. So you end up waking up and remembering your dreams, and you don't feel very productive during the day. You're not very tired, but you get brain fog and things like that. But if your tongue is falling back and blocking your breathing, if you rolled onto your side, that wouldn't happen so much. And
Because of
because
gravity, right? Like
yeah, we're just
the
using
different position
gravity.
is, yeah.
Thank God it's free. Yeah. So what I was noticing is that when I was doing my drug-induced sleep endoscopy, which is I do it slightly differently from other people, but during that test, because people are actually asleep rather than just sedated, they tend to roll over because they just can't breathe. And so you're just following them around like this to try and keep up with them. And when you look at someone's throat, when they've rolled over to their side, you see everything seems to change. You're like, what? And then some people naturally just slept on their front like this, or
Yes.
like they were sleeping like this. And I could see that the tongue was just rolling out of the way. And you can tell the only reason they're doing this is so they can breathe. And then I think I did a video years ago about positional therapy. And you could either have these big backpacks that
Mm-hmm.
basically you're like a tortoise. You physically can't sleep on your
Yeah.
back. You're doing this.
So yeah,
Um,
there's a bunch of different things, but like slumber bump, and there's like a noodle thing. It's kind of similar to back in the day when people would sew a tennis ball in the back of a shirt or whatever.
Yeah, so what I noticed was that a when you wear one of these huge backpacks, which physically stops you from ever sleeping on your back, then it works beautifully. But the trouble is when you sleep on your side the whole time, your hip hurts, your neck hurts, your
Yeah, yeah,
ear
yeah.
gets pressed, your shoulder goes numb because you're sleeping on it, and you're sort of desperately trying to roll off your arm. So I wanted to create something that meant that you were comfortable sleeping on your side, so you didn't wake up hobbling around or your ear getting these weird marks on them. So I wanted to create that pillow back there so that it was comfortable to sleep on your side. But also I thought to myself, well, I've seen people when they roll over onto their front and I'm looking in their throat while they're doing it. I can see that when they roll onto their front with their face into the pillow as such, their tongue rolls forward. The problem is that a lot of them tried this, but when they slept, their chin gets pushed right back and it pushed their
Mm-hmm.
tongue back even
Yep.
more. So I thought to myself, if we only could make like a massage chair type thing without it pushing my tongue back. So on my pillow, which you can see online at, I think it's iwantgreatsleep.com, but there's in the head part of my pillow, there's this huge letterbox, the hole in the middle. And the idea is that you stick your face into it so you can sleep like that with your chin not being pushed back. And it means that your tongue can roll forward out of gravity. So it's not just side sleeping, but I couldn't think of a good name for sleeping on your front pillow or something. So
Yeah.
and people understood side sleeping, but if you just want to sleep on your side, you know you're okay with that. That's great. But if you can sleep on your front and let your tongue roll out the way and it not block your throat, I think that's even better. What we would call the recovery position. That's the
Mm-hmm.
position we doctors put people in if we find them on the street and they've lost consciousness.
Yes.
It means they don't vomit and block off their breathing, and it keeps their airway open because you're sort of straightening out the airway, with that thing with the ansa cervicalis and the
Mm-hmm.
tongue out the way. And that is the best way to keep your airway open. I thought, well, let's make a pillow that makes it comfortable to do that. And it turned out to be a massive, like 3-year project. But
Yeah.
yeah, finally.
So you never made a product before, right? Like you just decided
No.
you were gonna just do it because how hard could it be?
Yeah. I completely underestimated it. I thought it would be, I
Well,
thought
you
it'd be,
did it though. It's amazing.
yeah, I can be pretty stubborn. And, you know, it was kind of fun. It's a different skill. The problem about
Yeah.
being a doctor in this country, particularly, is that you spend your whole life fighting and getting that job and writing papers, doing audits and showing how you can improve the department. As soon as you become top of the pile, the managers say, that's great, well done, and just do what you're doing and don't change. I kind of want to keep going. And if you don't, you just get bored
Yeah.
and you end up thinking, oh, I hate this job. And all of that stuff is just rots your brain. Whereas if you try to keep going and learning new skills,
Yeah.
you enjoy it more and you feel like you're actually helping as well. But
Yeah. Well, you definitely are. Like when I ordered I should just say I ordered this pillow, Side Sleeping Pro, are we calling it?
that's what we call it.
Okay. And when I first opened it up, I kind of thought it looked like really bonkers because it had, like you were describing, it's got like a hole in the top part. And I was thinking I don't know how that's going to be comfortable, but it really surprisingly is. And the other thing that's really helpful is there's space for all sorts of different types of CPAP masks. Sleeping with special types of pillows with CPAPs can be like really tricky, but this actually fits, and there's plenty of air around you. So even with a full face mask, I could sleep on it with, like my face kind of almost in the, people have to go and look at the pictures, but like your face is like in this hole. It's just so much better design wise than a lot of other things I've tried.
Yeah, I mean, I think just over last Christmas, I tried to wear a CPAP mask just because I thought it'd be interesting. And it is, when you first put it on, I find it really hard. And it
Hmm.
was quite useful to know because I had to make the hole bigger on my thing because I just made it just
Yes.
enough for that size. It was just like a slit. But as soon as I put that mask on, I
Yeah.
felt hot in my face and
Yeah.
it was hard. And so I had to make it bigger. Although it's hard for some people, but it's worth it for those CPAP people. I am changing the shape probably in a couple of years' time because there are little things, but loads of people are talking to me. So could you
Tinkering,
do
I
this?
bet.
Can you get rid of this seam
Yeah,
here and all
yeah.
that sort of stuff? So it's kind of fun, sort of
Yeah,
changing
that's
it. And
awesome. I know what I really want to talk to you about is, so you have like a thing that you're trying in London where you're doing an interdisciplinary team
oh,
with
right, yeah, the MDT,
all
yeah,
different, I think you have a dentist and all different people like surgeons and sleep specialists. And so that is what I think that we need. So I would love for you to explain to us, like, how did that come about and how's it working?
yeah. I've got a video coming up about what my theory
That's a
about
theme.
sleep apnea treatment. But when I think about sleep, I'm quite good at bringing the AHI down to less than 5 and all that sort of stuff. Anatomically, I can fix a sleep study. But I saw an awful lot of people where I thought, hang on, you're a bit overweight, or actually, you're really scared of sleep and you've got insomnia now. And actually, you've got restless leg syndrome. I can't deal with any of these problems. And so, although I was just doing my thing, opening up the airway and letting them breathe, there were so many other problems I was coming across. And I
Yeah.
thought, actually, you need to see the endocrinologist because your diabetes is out of control. We've got to sort that out. And I don't want to do an operation, you get infected, or
Yes.
actually, your heart's really bad. You need to sort that out. And actually, I think you've got restless leg syndrome as well. See the sleep neurologist. And I was getting confused, honestly. And I felt like I was having to learn all these other specialties, and I'm only good at surgery. And I thought to myself, wouldn't it be better than rather than me doing this for my whatever 2 years to fix someone's sleep apnea, and then passing them on to the next guy, and then he goes to the next guy.
Yeah.
It's all sort of a linear progression, and they spend years and years trying to sort out a problem that could be done in a year if we did it
Yeah.
carefully. So they come in, they see me, they see a GP, who's my wife, who's amazing. They see a sleep neurologist, probably the best sleep neurologist in the country, a max fax surgeon who does MMA surgery.
Hmm.
We
So
see
let's slow down. So oral and maxillofacial surgeon that does, it's called all different things, right? But double jaw surgery or MMA
yeah,
surgery or
or Bimax,
Bimax, or they call it all different types of things, but that's what you're talking about.
yeah,
Carry
and
on.
some palatal expansion type
Yeah, yeah.
stuff as well. They see a psychiatrist for the insomnia side of things. They see a cardiologist, endocrinologist, gastroenterologist, bariatric surgeon. So they see all of us.
Yes.
We do, I think, 4 nights of polysomnography. We do scans. We do loads of blood tests. So we do everything. And so the idea is that we do all these tests. They see these 8 or 9 consultants.
Yeah.
And at the end of
At the
that,
outset.
yeah, we haven't done
Yeah.
anything yet. Yeah.
Yeah.
And at the end of all these scans and CT scans and MRIs of the heart and all that sort of stuff, we get round a table, or in the pub or something like that, and we say, okay, what are we going to do with this guy, or what are we going to do with this lady? It says, well, she's going through menopause, we need to do this. So she's thinking of having a baby, we need to do this. Or he's really overweight, we need to start with this. And he's got exploding head syndrome and all these other weird stuff. Maybe we should sort out those problems first before starting on the sleep apnea.
Hmm.
So having everyone in the same room talking about one person and going, no, 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 you're right, we should do that first. And I'll back off until you've done that bit. And then I'll
Yeah.
jump in. It works so much quicker. Then I'm writing a report now. You end up getting like a 20, 30-page report where I bring everyone's ideas together and we say, look, we think we've done all the blood tests for looking at all the research in the world. These are all the best people that we have in England to do this sort of thing. In our opinion, this is the way to go forward. There are these other ideas that you have as well, but this is your problem and this is how we would fix it.
Yeah.
And then you bring in a whole bunch of other people as well, like functional breathing people, myofunctional therapists,
Yeah.
dentists, like you were saying, for
Yeah.
mandibular advanced device. Nearly everyone ends up with a mandibular advanced device to help them in the first stages.
Yeah.
And therapists, occupational therapists, someone to help with sleep hygiene. So it just feels just more connected, and you feel like you're not trying to, as a doctor, I only know it from a doctor's point of view, but
No,
from a
that's,
doctor, you just think, oh my God, I get help with these people.
yeah.
And yeah, it's so much easier for me. I can just stick to my surgery and do the bit I'm good at.
Yeah. Well, it's so much better for those patients too, right? So one of the things that I'm kind of obsessed with is this whole problem of silos, partly because of medical insurance in the States, but also partly just the way that interactions are between doctors and dentists. I maybe know like 2 or 3 places where they have some sort of interdisciplinary team happening. And everywhere else, it's just not the norm at all. And patients end up really doing all the legwork themselves. So you have people who, I mean, of course, if they do well on CPAP, that's terrific because that's what the system is kind of set up for.
Yeah.
But I end up talking to all the people that don't do well with CPAP. Even if they want a mandibular advancement device, I feel like almost everyone is having to start from find a dentist that does those like themselves, right? I would just love it if there were one doctor or one person who's kind of like managing all these different specialists, and but that just doesn't happen. So people just end up, finding out about treatment options and who offers them themselves and almost like working backwards, like, oh, I need a referral from this other doctor to this person I found. So I think that what you're doing is wonderful, and I hope that we move into interdisciplinary care being a much more standard way of looking at treating OSA.
Yeah, I've got to completely agree with that, because the more I look at sleep apnea, and this is my new theory, or not my new, I've been having this theory in my head for ages. I sort of think of treatment for sleep apnea like a meal. So there's no point just slapping one steak on the plate and just saying, here's your meal. It's going to be tasty, I guess, but it often doesn't complete the meal. And so you need veg and, spices and gravy or whatever you put on this thing. And so having surgery as your main bit, that may be perfect for you, but you'll probably need all the other things around it as well. But the idea is that it's really rare to get one treatment that will
Yes.
work for one person, because there is no way that sleep apnea, when you see it when you look inside people's throats. I look in my patients' throats and I go, you've got a problem here, 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 and here. And they
Yes.
go, well, 4 problems. And I go,
Yeah.
yeah, well, if we were so delicate that one tiny thing could go wrong and our airway would stop and we'd die, we
Right.
wouldn't have survived this long.
Yeah.
There's so much redundancy in our airway, that means that multiple things have to go wrong before you start getting sleep apnea.
Mm-hmm.
And so if there are multiple things wrong, you're going to need multiple cures for it. And then on top of that, we've got emotions, we've got the psychological stress of sleep, and you've got all the, oh, actually, I'm a carer, or, I can't actually do this because I saw my dad with a mask on when he was dying of emphysema. I don't want to go down the same route. And there's all this stuff on top.
Shame and stigma around the diagnosis at all, and also the treatment options for it. That's a whole level for some people. Yeah.
And all I'm trained to do is cut things out of people's throats.
Right.
I can't deal with the rest of it. I'm rubbish at it. And it's so, if we're honest, that obstructive sleep apnea is actually loads of different syndromes and loads of different causes and loads of different impacting factors, we should get a whole bunch of people in a team. It's like we do it for cancer in this country, and I'm sure it's the same in America.
Yes, it's definitely the same for cancer here, that they have a multidisciplinary, like they're working together, all the different specialists.
I was a cancer specialist years ago, and it's not, there's only about 4 people involved in that. But obstructive sleep apnea, even in my small one, my small MDT, it's got 8 people at least. And it's so much more complicated than cancer. So I'm all for it. The trouble is, I'm afraid it's not quite the same as it used to be. The NHS is doing exactly what I think America's doing. We're siloing everyone, as you're saying, and you often get passed from clinic to clinic. There are some centers which are okay, but none of us are great.
I think just being often the only patient advocate in the room at like different sleep conferences, I do find, like, I feel like we're maybe moving towards that slowly, but I do find it frustrating because you often just kind of hear people talk about it as there's a one singular solution. All I do is speak to people with sleep apnea all the time, and the vast array of experiences. I'll talk to a really older man who has loud snoring and a bigger neck, and kind of his snoring bothers his wife. He gets put on CPAP and he loves it and it's fine and takes care of the problem, never talks about it again. Then you have a woman who's really young and slim, and she has a tough time in the beginning getting any sort of diagnosis, right? Because usually she has like a lower AHI, so less events, but the impact on her life is pretty severe. And those people are really struggling to get the right kind of treatment. So I was like on a panel thing at the sleep conference earlier this year. And Ali Azerbaijan from Harvard was talking about this thing, hypoxic burden, right? And there's a lot of talk around, how we think about diagnosing obstructive sleep apnea and also like looking at severity. And so I'm just kind of wondering from your point of view, like, what do you think? Do you want to explain to people what the AHI is?
Okay, AHI in its simplest form is the number of times that you stop breathing every hour on average for the whole night. And the A stands for apnea, the H stands for hypopnea, and the I is just index. So that means the number of apneas and hypopneas over the night. Now, apneas are when you completely stop breathing, you go blue, you take a breath, just like I explained at the start of this. Hypopnea is exactly the same, but just not as bad. And the problem is that we say that apnea is 1 and hypopnea is also just 1. And therefore, how could this be as 1 if it's not quite as bad? The problem is we don't know sometimes hypopneas can be almost as bad as apneas, and sometimes they could be barely anything. And then on top of that, you've got rares and other things going on down there.
Right.
And the goalposts keep changing about what is an apnea and what isn't a hypopnea. And there's the classical definition and the alternate classification for hypopneas, and it gets so confusing.
So confusing.
And so some people, for some reason, just want one number that they can hang on to.
Yeah.
And I'm sure I'm going to upset every doctor in the world, but I don't like people trying to silo people into a number, trying to,
Right.
you can't say, oh, what's your personality type? Oh, well,
Yes.
I'm this. People are complex, and so
Yeah.
is sleep. And I think AHI is useful as long as you use it carefully. Like, for example, I often say to people, your AHI is 10 or something. It doesn't mean anything because it's through the whole night. And actually, if you
Yes.
look at your whole night, your AHI when you're lying on your side is 2. When
Right.
you're lying on your back, it's 20. When you're dreaming, it's 25.
Yes.
When you're dreaming and lying on your back, it's 45.
Right.
That's the sort of detail we need.
Yeah.
And so AHI is useful, but not as an average for the whole night, because our
Right.
nights do that.
Yeah.
And the same thing with ODI, the same thing with flow limitation, the same thing with paradoxical breathing, and
Yep.
all these little things. So, for example, same with, I think what you were saying, that he was saying that sometimes when you give someone a treatment, the AHA may not change at all, but all you've done
Right.
is change the apneas into hypopneas.
Mhm.
Although they feel better, their AHI may still be 20,
Right.
but actually they feel so much better. And you say, oh, it hasn't worked. But only if you look at the
Right. If you're only looking at the number versus the patient experience and looking at some other stuff. I think for a long time, it's almost been oversimplified where, doctors have looked at how a sleep study's been scored. They just say, okay, they're in this category, give them a CPAP if they meet the threshold. But I think now, hopefully, we're moving towards actually looking at each individual person and how
They're
to.
not, are they? They want a number, don't they? They want, oh, your hypoxic burden is 40, or your hypoxic burden is 900, or whatever it is.
Yeah.
And then they go, oh, right, therefore, at this level, you need CPAP.
Yeah.
And you're not allowed anything else. They want to make
Right.
it so easy that
I know.
Google can follow it. Whereas I'm trying to say to people, sleep is complex and it's
Yes.
difficult. And you've got thousands of numbers on a sleep study. Use the numbers
Yes.
and work out what's going on. It's the sleep study. It's not that useful anyway, because you need to talk to the patient and they might say,
Right.
I do move around a lot. And if you look carefully, I wake up a lot and it's really disturbing me. And whereas another person would say, I barely noticed that. I sleep right through the night. I know
Yes.
that you're saying it looks terrible, but I feel fine. And so it's your experience of that sleep studies
Yeah.
also should be counted in. And like
Yeah.
a lot of my patients, when I do an operation on them, I go, whoa, you've done so well. And they go, yeah, I feel great. But when you look at the AHI, the overall AHI hasn't changed much. I go, what? And before, because they couldn't breathe, they slept on their side the whole night going, trying to breathe. But when you do the operation, and now they're going, okay, when I slept on my back before, it was terrible, but now it's so much nicer. I can lie on my
Yeah.
back because now I can physically do it.
Yeah.
Their AHI hasn't changed because they're now sleeping more on their back afterwards.
Yes.
So little things like that
But their
are.
quality of life absolutely has improved.
I did a questionnaire years ago on that thing because a lot of people they go to their doctor and say, look, I'm on CPAP and I know the numbers look good, but I feel terrible. And they go, but your numbers look good. But then the patient would say, but I feel terrible. And they're
Yeah.
not speaking the same language. So I
Yeah.
made a questionnaire called STAMP. And I can give you the link.
Yeah.
It's a
Yeah.
free questionnaire. And it tells you more about how you feel and how it affects you. So when
Mhm.
you turn up to your doctor and say, yes, I'm using my CPAP. Yes, my numbers look good, but my STAMP score is not perfect yet. And so doctors like numbers, as you can tell with the hypoxic burden. This identifies you as that person. But if it gives them a number that they can hang their brain on,
Yeah.
it means that they can start thinking a bit more in a complex way about sleep, because it's a complex thing.
The last thing I was going to ask you was just what do you think we need more research into?
I think we're even close to dealing with the stuff that we already have. Personally, I think we've got loads of treatments.
Yeah.
And if you get a patient and you really listen to them and figure out what's going on with them, like my NDT patients,
Yeah.
you really get to know them. you get to know them properly, their sleep, how they interact with their sleep and what they feel about their sleep. Actually, the tools are out there. We're not good at all about picking the right tools for the right person because
Yes. Or the combination of lots of different things
yeah,
together.
yeah, trying to get that combination is the hard bit. And I think doctors like making it easy because it means that we don't have to think so hard. And but actually it's not like that. It's a bit like a psychiatrist. You have to tease out all the little bits and
Yes.
pieces and then lay it out and then okay, now I get it. Let's work
Yeah.
with through this one by one. And if we could be better at that, and I'm not saying I'm any better, I'm still bad at it, but if we could get better at figuring out if you're an insomniac, then if you're this type of insomniac, then don't have an implant. If you're this type of insomniac, then this implant would work really well for you. I've done implants on insomniacs, even though it's officially not allowed. They've done amazingly well.
Hmm.
And some people I'd go, there's no way I'm giving you an implant.
A
So
couple of the surgeons I've talked to that have done Inspire talked about people it working well where people had a very like a sort of normal you go to bed at night and you stay in bed for 7 to 8 hours and then you get up and go about your day. Like one surgeon I talked to was telling me a story about somebody who he would sleep for 3 hours and then he'd be up doing something else and then it was very fragmented and I feel like maybe it's more designed for an actual stretch of sleep at night like we would think of.
yeah, but I think like I agree. I mean, it's probably better for you to have a whole night's rest. But I mean, we historically we used to have two little sleeps at night anyway. We'd sleep for a
Hmm.
bit, wake up, pot around the house in the night, and then go back to sleep again. And there were siestas in Spain
Yeah.
and maybe other countries. So sleep has never been it hasn't always been oh, I go to bed at 7 and wake up at 6 type thing. It is different for lots of people. But I think there are some people out there who don't have very bad sleep apnea, have really bad insomnia because they're like this other chap who keeps getting woken up with the slightest interruption in his
Hmm.
breathing. And actually fixing that, the insomnia starts getting better. They feel better. They feel more confident about themselves. And then they sort of exercise more and they look
Yeah.
after themselves. Just edging them in the right direction. You can see it change. And each time I see them, oh, you've been on holiday. And they don't do holidays. They just can't face that sort of thing. But when you
Yes.
see that they're getting a girlfriend or getting a boyfriend and they're going out and say, oh yeah, I got a new job and that you can see it slowly
Yeah.
changing. They don't recognize that it's because they're sleeping better.
Hmm.
Yeah, if only we could understand that better, but I don't think we will because it's just too complicated right now for us. I think what will happen is just people who are interested in it will slowly get better at being better at figuring out this person in front of me. I hope that they're going to do well with this. I'm going to give them safe things to begin with and see which direction they turn
Hmm.
because sometimes people change as they go through treatment. They come in. A lot of people feel very frustrated and angry with the world, and then they get a bit better and go, "Oh, I've got a bit of control over this," and they feel a bit happier.
Yes.
And say, "Well, actually, I don't want to
Yes.
have every operation under the sun. Can we go back to devices now, or can we go back to CPAP?" And it's lovely to watch people weave in and out of all the
Yeah.
options. I don't think, personally, more options is a great thing. I mean, if we had a new option, that would be fantastic. But
It's
I
more
don't.
about getting the right people to what we already have in the right
Yeah.
combination. And yeah.
Stop thinking about sleep apnea as a simple one treatment fits all type thing. Just you're going to have multiple treatments. It's going to take a long time. And we're going to work through with you. We're going to get you closer to where you should be. And then after that, we'll just either maintain you or you can just leave me and you can come back if there's a problem in the future.
Yeah.
And just that gentle sort of transition back to normal, get you back on track is all most people need.
And I think also for a lot of people I talk to, sometimes it can be really helpful to change your mindset to think of obstructive sleep apnea much more as a chronic condition that you're managing. I
Yeah.
think that sometimes the mindset of that you must fix it, right, can actually kind of backfire and not be as great for your mental health. I think that for me, what's been really helpful is looking at do I feel a lot better than I did
Yeah.
before treatment? Yes, I feel much better. I feel like I got my life back. So is it perfect? No. And do I have some days that are better than others? For sure. but is it much better than where I started? Yes. And so I think that's kind of helpful to a lot of people rather than thinking, oh, there's a perfect solution. I just haven't found it. I think sometimes you can,
You
yeah,
can chase
maybe,
it. Yeah.
yeah, you're constantly spending all your energy trying to find this perfect thing that maybe doesn't exist.
I think people forget that when they were normal, they probably had good and bad sleeps anyway.
Oh yeah,
People wake up
for
feeling
sure.
dreadful, and
Yes.
not everyone wakes up feeling like a DJ. I mean,
Yes.
that people wake up feeling awful sometimes, and it's
Yes.
of no particular reason. There's
Right,
night to night
exactly.
variability in normal people, and it's with the smartwatches and the pulse
Yeah.
ox and you every day, oh my god, that he wasn't a smiley face, and oh my AHI went from 0.3 to 0.4. What's
Yeah.
happening? And you're actually, well,
It's fine.
track it every day. You're just going to get yourself stressed out,
I
and
think so too.
it becomes a thing that you worry about all night, and then I mean, it's really hard. It's easy for me to say, oh, you shouldn't be
Yeah.
looking at it, but it's more
That's
about.
that's one thing. I know I said final thing, but there's one thing that I didn't mention. So I am really interested in like remote patient monitoring for different treatment options. What do you think about that? Is that helpful? Do you do that with any of your patients? Like have them actually track whether it's like with a pulse oximeter or something to actually show you data for how they're doing with a particular treatment option.
I do with some people. So if I look at that person, I think they're not going to be happy until they track it and put it on a
Yeah.
spreadsheet like a notebook commando. They're going to be
Yeah.
there checking everything. And some people, I say, this is not for you.
Mm.
Don't check it every. I want you to tell me how you feel, really like sort of emotional, and actually taking them away from all those numbers relaxes people. So for some people, I say, yeah, go out and get a pulse oximeter. If you really want to know that your oxygen levels are better, get a pulse oximeter, use this mandibular advanced device or this implant, or we'll take out your tonsils and just tell me when your oxygen levels get down to a certain level and plateau off, those sorts of people. But then some people I say, we're not going to do anything for 9 months. I've taken out your tonsils. You're going to come back to me and we're going to see where you are at that point. So
Yeah.
don't worry about it. Let nature take its course. And maybe I get it wrong sometimes, maybe I get it right. I don't know. But you make a judgment call on each person and you go, for this person, I think they just need to be told to chill out, wait, let nature take its course. Then we'll do the test, the sleep study afterwards. Not everyone needs or should be looking at a sleep tracker every night because it's not good for them mentally.
I get that totally. Listen, thank you so much for spending time with me. I really appreciate it. It's been so helpful and super fun for me.
It's a pleasure.
Um,
Yeah, this is my
is,
first ever podcast, so I'm hoping I
is it
haven't
your
messed it up.
first one?
Yeah.
Hopefully, it'll be the first of many. I'm going to include all of the different ways to find your YouTube channel and all of your different resources in the show notes. But is there any particular places people can find you that you want to share?
Well, I do the YouTube channel. There's stuff coming out on there. I have a newsletter, so every couple of weeks or so, I talk about a thing like, the AD 109. I'll be writing about soon, that pill. And there's that questionnaires. I've done a questionnaire which I go through my stamp questionnaire, the nose questionnaire, and all those other
Yep.
things because some people go to the doctor and say, I don't feel well. And I think I've got sleep apnea. So, well, you're too thin, go away. Well, actually, I've done all
Yeah.
these questionnaires.
Yes,
This
yes.
says I've got a high risk of sleep apnea.
Hmm.
And so you can start communicating with your doctor. That's free as well. That's a free questionnaire. I'll give you the link on
Yeah,
that.
that would be great. Okay, I'm going to put all of the links to all of your stuff in the show notes so people can check it out. And I appreciate it so much. Thank you.
Thank you very much.
Thanks so much for listening. I love hearing from you. If you'd like to be featured in an upcoming episode of the podcast, please email me at sleepapneastories@gmail.com. That's also the place to get in touch if you just want to say hi or ask a question. Alternatively, I'm over on Instagram. My handle there is Sleep Apnea Stories. If you're enjoying the podcast, please subscribe or follow, rate and review wherever you listen. This really helps a wider audience find the episodes, and I really appreciate it.